Hello, everyone. Welcome. Welcome to one of our online evidence-based journal clubs for GoldNet. So fantastic to see you all here, and thanks for making the time. We'll start by Ali will share her screen so we can introduce our speakers tonight, and we'll get things underway. And as usual, we'll make sure you're all finished by 8 so you can get on with your evening. So for those who don't know me, my name's Zwar. I'm Executive Dean at Faculty of Health Science and Medicine at Bond and Chair of the GoldNet Steering Committee. And then we have with us tonight Dr. Maninder Singh, who's Director and Head of Respiratory Medicine at Gold Coast University Hospital, and a Senior Consultant Respiratory Specialist and Associate Professor Honorary Adjunct at Bond University. Associate Professor Henry Marshall, who's a thoracic physician at the Prince Charles Hospital and University of Queensland Thoracic Research Centre, and our own Associate Professor Loai Albarqouni, who is an Institute for Evidence-Based Healthcare. And Loai is coming to us all the way from Denmark today, where he's about to attend the Preventing Overdiagnosis Conference in the near future. And tonight is about a very topical issue, which is introduction of the National Lung Cancer Screening Program. And we're really going to, as well as a bit of the evidence about why this is happening, what's the evidence on whether screening can detect early lung cancer and make a difference to patient outcomes, also some of the implementation opportunities and challenges, because they're not small, and there's a lot of challenges for primary care and for secondary care in how this is going to roll out and how we of this new government-funded screening program. So thanks, Ali. Next slide. So we'd like to start by acknowledging the Kompi clan of the Yugambeh language-speaking group and the traditional custodians of the land that I'm sitting on here in Gold Coast, and pay our respects to elders past, present, and emerging for their wisdom, knowledge, and teaching and cultural knowledge. And this is an artwork by Narelle Urquhart, who is an Aboriginal woman who was at Bond University till a few years ago and is a local to this part of the world. Okay. Professor Catherine Wallace from the University of Queensland, who's going to present a short study to get us started tonight. We'll come to Catherine in a moment. Ali's going to keep us on time and guide me if I get things wrong, which is not uncommon. The welcome and the case study is going to be done by Professor Wallace. And then we're going to go to Loai, who's going to take us through a systematic review of lung cancer screening, advancements and strategies for implementation. This was one that was done in the context of the European setting, but I think it has relevance for Australia. And then we're going to have a discussion with help from our guest speakers. I know Henry has a few slides to show, so we may do that after we've had the discussion of the article, and then I think that will set the scene for the broader discussion of implementation challenges and how to manage unexpected findings that might show up when you do a low-dose CT, and some of the issues around actually if you find something on the CT, what happens next and where are the opportunities for the diagnostic tests and further investigations which need to happen. There's a lot to talk about. So we may go then, I think, next, if I'm right, to our case study. Is that correct, Ali? Is that our next thing? Yep. And I'll hand over to Catherine.
Thanks, Nick. So I'm just going to present very quickly this 67-year-old man who came to see me. I met him for the first time in 2023. And he'd come about sort of swollen ankles, and we worked out it was due to his blood pressure medication and changed that. So he's a director, a sort of a family business, spends a lot of time on the road, has quite a stressful and unhealthy lifestyle. He's now an ex-smoker. He's smoked for 45 years, since 1978, in the sort of 20 to 39 cigarettes per day box, as you can see in that sort of best practice history smoking screenshot there. And so he stopped smoking just last year on a using vaping prescriptions. He used to be very overweight. He had a gastric sleeve in 2013 and lost 42 kilograms following that. He's not on a lot of medications, and he's recently had some sort of cardiovascular disease and risk issues and investigations, but the angiogram wasn't very impressive, actually, so he's not had any sort of changes or any treatment subsequent to that. So next slide, Ali. This is just a brief potted history of his presentation, or some of the presentations to me. So I first saw him at the end of November in 2023, and at that time my notes said, "Not keen to give up smoking. No way. Is my life, is my stress relief, work, life, family, etc." So that was on the 24th of November, and then I saw him again on the 1st of December. So a little over a week later, and we did a cardiovascular disease risk assessment and talked about smoking again. And then he had changed his tune quite dramatically. And my notes at that time said, actually would consider trying vaping to come back to discuss with Dr. Zwar. So at that time, that must have been sort of fairly soon after the prescriptions for vaping came in, round about that time anyway. And I hadn't, and still haven't actually done the training and to be able to be a prescriber. So I refer patients to another doctor in the practice who's got an interest in that. And then he was seen by Nick on the 8th, so about a week later. Long-term smoker, first cigarette soon after waking, high level of nicotine dependence, tried patches and hypnosis without success. And then he started the vapes on a high dose of the liquid. And then he stopped smoking fairly quickly and was able to reduce his nicotine vaping dose over time. He is still vaping. He's had one sort of, what do you call it, sort of lapse where he got back into cigarette smoking, but then pretty quickly back on the vapes again now. So he's still not smoking. And he mentioned to me that he'd seen the advertisements for the lung cancer screening. And, did I think that was a good idea? So that's really probably as far as I want to go with the presentation of the case.
Hey, thanks, Catherine. I imagine there's a few questions that come to mind for us from the case, and we'll probably pick them up as we go into the discussion, I think. So maybe we'll hand now to Loai, if you could take us through the article, which was a systematic review. So over to you, Loai.
Thanks, Nick. I think I'll share the slide. Or Ellie, do you have those slides, or I send them late? So.
Yeah, I've got them. Did you want me to just flick through?
Perfect.
Yeah,
yep.
Just say next slide when you're ready.
Yeah. So this article is a little bit not the usual one. So it says not a systematic review of the specific questions, a little bit about, because it's about implementation, how to implement that lung cancer screening program in the European context. But I think there are a lot of lessons to be learned from this article. So the next slide. So the first thing is to look at what's the key question of the article. If you click next, Ali, sorry. That's a little bit annoying with those kind of animation. Sorry. So I think those are the questions that we will go through them today. What's the key question of this article? Are the results kind of valid, and can we trust the results? And then we will dive in the results of the review and how we can take some lessons from those results. And so this is the article, and I think you have the link to the article in your in the invite. So the first is, what's the key question of this article? And most of the time, the key question is in the abstract or even the title. But here it's in the last kind of paragraph of the introduction. They would like to give us an overview of the lung cancer screening trials and program in the world. What's the benefits, what's the harms, and the limitation of its implementation in real world. So that's kind of the main aim. So the population is kind of people eligible for those lung cancer screening program. The intervention is lung cancer screening, whether that's low dose CT scan or other, and compared to chest X-ray or usual care or no screening. And the outcome is benefit and risk, and what's the challenges. So usually we use faith to kind of critically appraise those kind of studies, but this is a little bit, we will use only the find, appraise, and the included, because it's more of a scoping review rather than a systematic review. There isn't a lot of kind of pooling of those results. So if we go next to the find, so they did kind of assess a strategy to look at the literature around a lung cancer screening program that's conducted in October 22, and they looked at two databases, the PubMed and Scopus. There's some limitation around using only English language articles, which can lead to language bias. So looking only at the articles that publish in English, which kind of overestimate the benefits and underestimate the harms and risk. But I think for this context, because it's we are thinking about the applicability of those findings to Australian context, which is English speaking. So I think it's not that a huge kind of difference, or it won't lead to huge bias in that regard. We have, I think the research is very simple. It's not that complicated. They can do it better, but I don't think looking at the trials and compare that to other systematic review that have used more comprehensive search strategies, they haven't missed a lot of kind of key literature in terms of trials. So it's not the best kind of search for the relevant article, but in the same time, it's not. It's good one. It's fair, I would say. In terms of the inclusion, in the next slide, or the appraisal in the next slide, they have used, because it's a different type of studies, not only randomized trial, they use kind of a checklist that they have developed, but they include the key elements of the usual kind of Cochrane randomized risk of bias assessment. That's some random assignment, some outcome assessment, measurement, but they have added a little bit about the comprehensive diagnostic workup planning and the adherence to the inclusion criteria, some of the key aspects for the implementation of those lung cancer screening program. But they have done some kind of appraisal of the included studies, and they rank them and with that regard. So in the next one about the inclusion. So here's their inclusion criteria. So I think it's just, again, from the research questions about people who are eligible for lung cancer screening program, and most likely in most of the studies about low dose CT scan as a screening program, but there is a variation around the interval for that and the eligibility criteria of the population, and compared to either chest X-ray or control, that's no screening program or usual practice, and the outcome for the trial, most of them reported around cancer mortality, lung cancer mortality. I think that's kind of the critical appraisal. Now, I think let's go to the results. So I think next to the result. So the first thing is around the benefit of those lung cancer screening program. There are a few trials that have been reported. One of the largest trial in the US, that's National Lung Screening Trial. And for this one, there's variation, as I mentioned, in terms of the screening, the screening method and what's compared to. So in this largest trial in the US, it's low dose CT scan compared to chest X-ray. And the interval is annual screening for 3 years. And the eligibility, I think, in terms of the eligibility, this is one of the closest to the Australian lung cancer screening program in terms of the to be eligible for this screening program, the individual need to be 55 years to 75 years old, and they have to have 30 back year or more. And for those ex-smoker, they wouldn't be eligible if they are more than 15 years ex-smoker or quit smoking. This trial have enrolled over 50,000 individuals and followed up for 3 years, and they found about 20% reduction in lung cancer mortality. The next largest trial is the Nelson trial, the Dutch-Belgian trial. And interesting for this trial that they have compared low-dose CT scan versus usual care. And they have a little bit different eligibility criteria in terms of they have used some kind of risk scoring prediction models to enroll the population to that trial. But they found also similar reduction, around 24% reduction in lung cancer mortality. So similar to the US one. There are a few smaller trials, include the 2 Italian one, and one of them, the MILE trial. I think there's one interesting bit in the MILE trial that they have also did further sub-study within the MILE trial, comparing annual one and biannual one, which is, I think, the Australian biennial kind of frequency, and they found that they are kind of similar benefit, and showed also a kind of a reduction in lung cancer mortality. I think that's in terms of the benefits, but I think all those trials, they have found also an alarming concern around the false positive and overdiagnosis. So just an example, in the US trial, one of the largest one, they found after the first year screening, they found that so first, the positive result is about 1/3 of those who have been screened in the first year were positive, and over 93 or 92% of them were false positive in the first round. So that's a huge amount of the population have been kind of false positive, with all the subsequent kind of individual and system burden. For individual, there's about, I think at the end, there's about 3.7% of who have been screened and have been false positive have some complication from that screening program because of the biopsy. All that's kind of individual kind of complication, but also there's some implication in terms of in terms of the system burden. But also an interesting finding that there is around 10% in that US trial after the first round, there is 10% non-lung cancer finding that have been found through the screen that needs some kind of follow-up. So not related to the lung cancer, but kind of maybe incidental finding as well. So that's in terms of the harms and benefits. So I think the major harms is around false positives and the subsequent kind of workup and complication, system and individual, and the overdiagnosis. So if we go to the next slide around, we have also some kind of comparison around, or the next one, around the different screening program that have been implemented. So here's kind of the US one, and there's the last two is the European one. So there's some variation, but it seems like the US, all of them have been annual screening interval. And the majority of them is around starting at the age of 50. Some of them end up 75, some of them 80, and there is some variation around the eligibility criteria. And also about whether they're using only the smoking history or more complicated risk-based approach. So if we go to the next one, is around about those kind of risk prediction models that have been developed. I think the BLCO cancer screening trial kind of risk prediction model, that's I think the UK is trying to implement, I think from reading some of the texts, as trying to implement that one. And also that have been suggested to the Australian, but I think the MSAC has been more kind of opt into the smoking history approach. And the next one is around the cost effectiveness of those trials. And it seems like from all those trials, it's cost effective to do the lung cancer screening. I'm highlighting this Australian case, a study that's looking at the lung cancer screening and applying that to the Australian context. It seems like if the Nelson-based scenario, it seems like the cost per adjusted quality adjusted life year is around 40,000 Australian dollar, which is lower than the US kind of estimates. I think the last slides, which as I found is really important and highlighted, is about the smoking cessations within those trials. And there's some work around whether to take that as an opportunity to try to advise an individual that's coming to the screening program to quit smoking, as it's one of the largest kind of risk factor for lung cancer. And there's some work here, which I found is surprising, that in that study by Badet et al., that's only about 15% of those who have been attended the low-dose CT scan have been advised to stop smoking. It's higher than those who haven't attended, but at the end of the day, it's only 14 or 15% or less have been advised to stop smoking. So I think there's recent more work about trials how to improve that percentage or proportion of counseling for stop smoking. I think that's from me. I'm happy if there's any question around that.
All right, that's fantastic as always. And maybe we'll bring in Henry and Maninder here. I might start with you, Henry, if that's okay, and ask for your comments. And you may want to show your slides, because I think probably complement and illuminate some of the issues that Loai's raised there. Is that okay?
Yep. Yeah, absolutely. Yeah, thanks, Loai, and a really good overview. There's so much stuff to talk about, isn't there, in lung cancer screening, right? It is, you know, quite, once you start sort of scratching the surface, there is a lot of complexity to it. And, you know, in Australia, and hopefully some of you will already have patients that are going forward to the National Lung Cancer Screening Program. Australia has opted for a sort of more simpler sort of American style approach, just based on the age and the PAC years. Even though data shows that the risk model approach actually does a better job. And importantly, you know, one of the things that doesn't come through on this paper, which is particularly important to, well, any screening program, is that because most lung cancer is associated with smoking, and we know that smoking is, you know, one of the sort of social determinants, right, of disease. It's tightly linked to, you know, the have-nots, the sort of the less advantaged populations, and a lot of priority populations, and that's where, you know, lung cancer tends to cluster. But actually making sure that your program reaches the people that it really needs to reach is really important. And that's a huge implementation priority in Australia, getting to our First Nations Australians, absolutely, but also thinking about, you know, people in rural and remote areas who have, you know, poorer access to everything, right? So, you know, if we're going to make a big impact on lung cancer screening, it has to get into those target groups. Otherwise, there is a risk of really sort of oversupplying the sort of metro kind of populace who are already well catered for, and just widening that gap in sort of health equity that we already have and that we already know. So it doesn't come out in that paper. I think maybe, I'm sure that the European countries have exactly sort of similar issues, but in Australia, magnified by geography, as well as our sort of colonial history as well. But look, I could go on about this for a long time. I mean, maybe, you know, if people have got specific sort of questions, or I can keep kind of talking on it. I mean, up to you, Nick. I mean, I could talk about smoking. You know, there's been actually this review kind of, again, just scratches the surface. You know, you can't do, you know, justice to a huge, you know, amount of literature really in one review paper. So I think, but I'm glad that smoking is in there because it's key. So one thing that I would think about, and I would ask you to really think about, is that, you know, most people who come for lung cancer screening will not have lung cancer. So we're looking at maybe sort of 3%, maybe 5%, and the rest will not have lung cancer. So what's the benefit for people coming through for screening?
Sounds good.
Cancer? And so, you know, we expect that at least half, maybe up to 3/4 of people who are eligible for screening in Australia will currently smoke. And therefore, the biggest single benefit that they can get is for you, for us as a health, you know, practitioner community, is to help them quit smoking. And that's going to affect obviously not just their lung cancer risk, but COPD, myocardial infarct, stroke, you know, you name it. There's at least 40 conditions that are linked with smoking. And that's why lung cancer screening has been shown to have not just a benefit on lung cancer specific mortality, but it's got a benefit on all cause mortality as well. So smoking cessation, we cannot forget it. We have to really get that right, I think. I'll stop there. I'm sure there's other comments and questions.
Maninder, would you like to comment at this stage, and then perhaps we go more into the implementation side of it?
Yeah, actually, I have a question for Henry, to be honest. Henry, you touched a very important aspect, which is remote communities and, you know, where services are limited. I used to do a clinic in Cherbourg to get a CT scan, and Cherbourg is not far away. It's only 350 km from here. To get a CT scan over there was a major ask because people have to travel about 100 kilometers around, right? So I think that is a very, very important aspect, is how we encompass that communities. I know that there is a CT scanner on a truck by Heart of Australia, but I think that is probably, again, scratching the surface. There will be limited reach. Is there any other ways to capture those communities with the screening program?
Yeah, no easy way, Maninder, I think. And you're right, every state is going to have a mobile CT scanner funded by the government, and it's going to be Heart of Australia that runs those trucks. And they've already started their implementation. And there's a long lead in for this. You can imagine you can't just rock up to a remote community one day and expect you're going to have a queue of people there. So the sort of consultation and the engagement with those communities starts a long time in advance, working out, you know, exactly how to do it. You know, Australia is second only to Japan in terms of CT scanners per head of population, right? We beat America, right? But they're all down the coast, basically, not very much inland. So, you know, I think in practical terms, it's basically the person's got to travel, or they've got to wait for the truck to come round. And I'm not quite sure how good the trucks are going to be getting into really remote communities and some of the sort of like roads and whatever. You know, breast cancer obviously gets out to a lot of places, but, you know, these are big, you know, massive road train trucks, essentially, right? Huge things, not breast screen kind of trucks, which are a lot smaller. So I think, you know, we're going to find out a lot more about this, the sort of the capabilities, right, of these trucks. The government's also talking about having some sort of travel allowance or funding for people in remote communities to sort of come in and have their travel costs covered. So that might be something to help. But look, when we think about screening, we have to think also about, this is the first step potentially in someone's journey through a lung cancer diagnosis and treatment, and hopefully catching it early and curing it. And so the barriers that we can sort of envisage for screening are exactly the same barriers, Maninder, right, that we see for any patient, right? You know, someone with lung cancer. I mean, telehealth has helped a lot. I mean, I'm sure that you use it a lot. I use it a lot. That's getting some of the way, but still, if you want treatment, you still are going to have to visit a metro center that's got the diagnostics and all the other tests, and then the treatment modalities that people need. So, you know, it is a big problem. I don't know what the answer is for that.
Sure.
We should explore that. Sorry.
Yeah, I'm happy to talk whatever you like.
Well, I guess it'd be interesting, Henry, to hear your thoughts on the treatment or the journey in the Gold Coast, in our area, and I see Mark Morgan's, what's the capacity locally? Because if I understand it correctly, people need to be referred by their GP to one of the radiology practices that's doing it, and that's fairly simple. And our radiology colleagues are pretty quick if they see an opportunity in private to start offering things. It'd be fair to say they're not slow with a commercial opportunity. But then if something's detected, what happens next? And also the diagnostic services that follow, because there are some diagnostic interventions that need to occur before you can say whether or not someone actually has a early lung cancer that might need to be treated. And then we might, after that, to what about all the incidental findings? So, but can you talk us through the journey, Maninder, in our local context?
Absolutely. Nick, we've had so far 6 referrals, since the screening program started. So once high or a moderate risk nodule or suspected malignancy is identified by the radiologist, he sends a very comprehensive result to the GP, and the GP has a choice of sending the patient to public or a private. In the public system where I work, we see about 600 new lung cancers a year. Now, this is before screening program. We run 2 lung cancer clinics a week to cater for those 650 and the review cases. Again, the best evidence of management of lung cancer is that patient has to be seen within 2 weeks of a referral by a GP. He or she must have a diagnosis done by 4 weeks and be on a specific management pathway by 6 weeks. And we audit our service and we strive to achieve those targets. In saying that, with the lung cancer screening, we will be seeing much more. I did a presentation to our local PHN a few months ago, depending on our HHS, and we believe we will be getting somewhere about between 200 to 400 new cases a year, and that is based on the uptake of the screening. So if we assume that the uptake is about 18 or 20%, which is in most of these studies, we'll be seeing somewhere around 200 to 225 new cases in either a nodule clinic or in the lung cancer clinic. With the current resources, we won't be able to handle that, and I'm already in touch with the executives to say if there is, that can be looked at. So far, there has been no funding about nodule, MDT, or a nurse, or any other resources. So that is a public pathway. Now, my colleagues are also seeing patients in a private setup. Now, in a private setup, a patient who does not have insurance, he or she can be seen there and be bulk billed. But the question comes, if that person needs a procedure. Now, they are not willing to provide a service in the private without, because there is a cost involved. So that means that will be trickled over to the public system as well. Second thing, they do not have access to advanced bronchoscopic procedures. On the Gold Coast, for example, mediastinal staging is a part of our care, and we do it with the help of our endobronchial ultrasound. In the private, there is only one physician providing it. So there is an enormous amount of work which will come our way from that aspect as well. Secondly, there is another procedure called a radial EBUS, which is for very small peripheral nodules. And some of these patients might need access to that service, and that is not provided anywhere in the private system. So I think we are looking at more referrals from the private as well. So yes, it is going to be in near future. It will be resource intensive unless something is done. Have I answered? Is that what?
Yeah, that's. I think that was, and I guess that impacts on waiting times and patient expectations, and as GPs, helping our patients to understand what they might experience as they go through a system which is going to struggle, on the sound of it, for all the reasons you've said. And thanks for explaining those sort of more complex diagnostics, which I think wasn't entirely clear to me when I was reading about this, that, you know, there's more to be done than just the CT by a long way. Henry, I see you've got your hand up.
Yeah. So look, we foresee exactly the same problems, right? And I think every thoracic physician that I speak to in every hospital system has sort of raised the same issues. I think that first of all, the bulk of the work for the National Lung Cancer Screening Program is going to be done in primary care, right, with GPs. You guys are going to be seeing 90% of what comes through, because most people will not have a cancer. They will have, nothing on their scan. 80%, 75% will have nothing on their scan, and they will just roll back through the screening program in 2 years. And then a smaller proportion, sort of 10 to 15% may have something that requires a scan at 1 year, 6 months, or 3 months. And those reminders and all of the invites will be done through the National Cancer Screening Registry, but the GP is the person to write the form, right? So the screening registry is not going to be requesting the CT scans. That's going to be for the GPs to do. So a lot of that is going to fall to you guys. As Maninder said, we will be asked to see the category 5 or 6, right? So there's 6 categories of risk, and the 5 or the 6 are basically the top risk, at least sort of predicted 30% risk of cancer. But we know from our data, Australian data, only about half of those will actually be diagnosed as lung cancer, all right? And half will be, patch of pneumonia or something, that's benign or whatever. So there's a lot of challenges. We are kind of working this out a little bit as we go. The government's funded the CT scans, but basically once you've been diagnosed with a high risk thing or an incidental finding, it's back into the clinical loop and all of our normal kind of pathways. So we're going to have to work out our new models of care as the lung cancer screening program rolls out. But there's already some really good good news stories that's come out of the screening program. So in Australia in July, the first month of opening, and this is without any media release or any public sort of campaigns, 5,000 people signed up for the program. 4,000 people had their CT scans. There's some great news stories. If you sort of Google one, there was a guy who had his scan on like the 2nd of July. He was diagnosed with an early stage cancer. He had his surgery 2 weeks later, and he was back at work, within, before the end of the month, essentially. So, although we can, this is going to make us really sort of rethink how, our models of care, and it's going to put some pressure on the system. The impact that this makes on people's lives is fantastic. Lung cancer is the leading cause of cancer mortality in Australia, and it doesn't need to be that way. And the National Lung Cancer Screening Program has been so long awaited, and it's having a huge impact already. So we've got to keep thinking of those positives. It is, a really great program that we've got. We can kind of, we're clinicians, we can kind of deal with uncertainty. We can work out stuff. We can roll with the punches, and we know that we can, do a good job. I probably sound a little bit over optimistic, really. But, I think I'm really pleased that this is happening. And I don't want to detract from any of the sort of healthcare system issues, but I think it's overall a very good thing.
Henry, that's dose of enthusiasm. It's very welcome. It's always good to have. Do we want, Mark, do you want to ask your question at this point, Mark Morgan?
Yeah, so my question's about the incidental findings. I think a study that compared low-dose CT screening was published recently, comparing 2 sites, Brisbane and Sydney, but they were finding about a 78% incidental finding on low-dose CT scans in these smokers, of which not all needed any action, but there's going to be a lot of them. And my concern was about the amount of challenge that GPs will face in managing those people if they're in a long queue to get seen about their incidental findings?
I suppose Maninder and Henry to comment on. So I know that Cancer Council or Cancer Australia have produced a guide for the incidental findings. I haven't had a chance to look about it. I heard about that the other day, and Henry, you might want to speak to that. But Maninder, in the local context, I mean, this will be things like a patch of emphysema. It might be, something on the pleura. It may be coronary artery calcification. Slightly enlarged mediastinal node, whatever.
Absolutely, yeah. So, so by the way, all our referrals are triaged every day by a consultant, right? So, if we believe it is lung cancer based on the CT scan, this patient will be seen in the lung cancer clinic within 2 weeks. If the findings are other than highly suspicious lung cancer, like interstitial lung abnormalities, incidental cysts, some asbestos or emphysema, then depending on the acuity, it becomes category 1 or 2. And all category 1 in the public system are seen within 30 days. Now, category 2 and 3 has been a problem in the past. We are breaching those, but I believe all these incidental abnormalities will highly likely to be category 1s, and we strive to see them within 30 days. The study which Morgan mentioned, that is very high rate of 78% of incidental. If that is true, then it is quite worrying, because there will be a lot of referrals coming our way.
Can I chip in as well? Yeah. Okay. So the issue with incidental findings is there is no standard definition of either what is, and there's also no standard definition or way to report this. All right. So we see huge heterogeneity in the published studies as to what is and what isn't, and that's why these proportions vary so much. So with the National Lung Cancer Screening Program, what we've really focused on is actionable incidental findings. All right. So a radiologist wants to report every single thing that they see. All right. That's what they're kind of trained to do. In the screening domain, it's kind of different, right? It doesn't really make that sense, so much sense. These are people who are entirely well. So it's really trying to think about the actionable stuff. And the big ones, I think, are going to be coronary artery calcification, COPD, and probably osteoporosis would be my sort of pick of the top 3. Now, these things you may already know about. The radiologist does not know your patient and will not get a sort of full history on the request form. So you will know your patient, and maybe you already know that they've got ischemic heart disease, they're on an antihypertensive, you're dealing with the cholesterol. It may not create any extra burden of work for you at all. You'll just look at the report and go, yep, we already know that, and we're dealing with it. But in a proportion of cases, and I don't know how many, this will be an entirely new finding. All right, this will be something that is hitherto completely unknown. But this is a great opportunity for preventive medicine. So someone with severe, and they're not going to report mild coronary artery calcification, right? So Ranska, the radiology college, has gone through and produced a guideline in conjunction with, and I think RACGP and the Rural College of GPs has had an opportunity to feedback on this. The thoracic physicians have, the cardiologists, the GI guys, everyone's had sort of input. So they've really kind of tried to pick out what are the kind of really important things that we're going to mention, and we're going to ignore the rest. So because no one else knows the patient than the GP, it really comes down to the GP to work out, okay, what do I need to do with this? Do I need to action it? Can I just deal with this in community? But it again could be, and going back to the sort of all-cause mortality, could be really important, right? For the patient, you've picked up, they've got some severe coronary artery disease, they get referred on, they get a stent, they avoid, an MI in the community or something like that. So yeah,
Thanks, Henry. That's been helpful. I'm conscious that we've got Loai's raised the question about uncertainties in the screening program, things like, the interval of screening, should it be annual, should it be, what should it be, how to work up. And maybe, Henry, do you want to speak? I know you've got a few slides, and maybe that's the time now to show those if you can.
Yeah, sure.
Just give us a bit of a quick update, because I know you're doing a bit of study about other alternatives to the current program.
So the biennial program is evidence-based. We've heard about the MIL study from Italy and the Nelson trial as well, which also brought in a 2-year interval. And there's no signal to say that you actually start to get more advanced cancers coming through on a 2-year interval. So you still maintain the benefit of early detection and early stage cancers, but you immediately slash your costs by 50%, right? Because you're not doing a scan every year. So it's fine in terms of health outcomes. It's definitely good in terms of budget. But look, just a couple of slides here, and you may already have visited the National Lung Cancer Screening Program webpage at the Department of Health. Just a few points that you already may be aware of. The NCSR, unlike other screening programs, it does not have the remit for inviting potential participants, because we have no idea what the smoking history is, right? And you can only find that out if you're basically the GP asking the person. So that's why it really comes down to the GP to work out the, whether they've got the requisite number of pack years. But you will be asked to register your patients on the NCSR, and that is, I believe, integrated into the top 3 clinical practice software down at the bottom right, best practice, medical director, and community care. So hopefully that's kind of working if you've had a chance to look at any of that. So the recommendations really from the department is to make sure that smoking history is updated in your clinical record, because that's the kind of key thing that that's going to help you work out whether a person's eligible or not. And you might be able to set up some prompts. I don't know, how your best practice works, but maybe there is some way to say, this person's going to become eligible when they hit, 50 or whatever, and flag it for that time. Next slide, please, Ali. And there's a lot of education resources which may be helpful. So you can scan these QR codes or screenshot this page. The stuff on the left produced by the Lung Foundation Australia, and the stuff on the right from the Department of Health. And a lot of information there, but hopefully in a quite sort of digestible format for various different sectors. So stuff for general practitioners, stuff for radiologists, stuff for thoracic physicians, etc. Next slide, please. And so just to sort of reiterate the eligibility criteria for the national program: 10, 30, 50, 70. So it's basically 50 to 70 years old, 30 pack years, quit within 10 years. So it is a high risk cohort. These are more stringent criteria than what the US is using, and many other countries as well. So we're really sort of going to the sort of apex, if you like, of risk. And the person has to be asymptomatic from anything that might suggest lung cancer. And of course, if they've got symptoms that might suggest lung cancer, don't put them into a screening program. Get straight on and start investigating as you normally would. And then the next slide, please, which I think is the sort of final slide, just to mention that you may have been, or in the future, you may be approached by people who do not meet the National Lung Cancer Screening Program eligibility criteria. All right. So I'm thinking particularly people in their 70s. All right. They are not eligible. People who have smoked 20 pack years or 25 pack years, they are not eligible. People who have quit 12, 15 years ago, they would not be eligible. All right. So what do you do for those people? Well, I'd like to talk about a couple of trials, clinical trials that are open. So if you do get people who are sort of near misses for the national program, then certainly we've got our doors open and we can offer screening in the research setting for these people. So next slide, please. So these are the 2 studies that I highlight. So the one on the left is the Max Up trial, and this is across Queensland, and it's for people who currently smoke and who want to quit smoking and get lung cancer screening. All right, so we will screen them for free, and we'll give them free smoking cessation support through Quitline and free NRT and all the rest of it. So that's for anyone in Queensland. We've got about 45 or 46 CT scanners contributing to that study. So hopefully people can find a CT scanner near to them. And then on the right, we've got the Australian lung screen trial. So you can see for both of these trials, we go up to the age of 80. And for the ALST, we're also very interested in people who have never smoked. So in Australia, about 20% of people with lung cancer have no history of tobacco exposure. What do we do for them? We really don't know. So this study is going to try to recruit people at risk of lung cancer. And then we've also got a mobile truck that will be up and running by hopefully New Year. And we're also recruiting Indigenous Australians specifically as well. So we've got sort of 3 arms to that trial. So please be aware that there are other options around for patients who can't get onto the national program, and I'm happy to take emails or whatever in the future. If you've got any kind of questions, please reach out. And I think that is the last slide that I had. Yeah. So look, I think sort of to come back to that. Okay. The National Lung Cancer Screening Program, as I see it, is the first step on a program that is going to outlast all of our medical careers, right? I'm going to be retired. Breast cancer has been screening since the 1980s, right? So that started before, so this is going to go on, and it is going to be iterative. It is going to be refined, and it is going to use the data that it collects to make sure that it's doing the job that it needs to do to expand the eligibility criteria where necessary to get more detail and advice around the incidental findings, and hopefully just get better and better as time goes on. So there's going to be lots of research studies ongoing. This is not the final word in lung cancer screening in Australia, that's for sure.
Okay, thanks, Henry. We're running out of time, so any quick questions from our participants before we go back and just think about our case very briefly and implications for our patient? Comments from the audience, questions from the audience. And there's so much to think about here, and I'm sure it is going to be iterative. Maybe go back to you, Catherine, if that's okay. And what's this mean for your patient?
It's hard to say anything but be positive about it with Henry still on the line here. But yes, I must say I'm sort of and anyway, he's keen to. He was the one asking me about it. He'd seen it advertised, so there's no way I'm not going to be referring him and getting him started on that track. But I think Mark raises an important question about all the incidental omas. I mean, I already struggle with radiologists reporting one test and recommending another because they've seen some blurry something or other on the first investigation. So, it is going to add to our workloads as a GP, I should think, trying to manage all that. No question of it. So, yes.
Thanks, Catherine. That's one thing we're certain of in primary care is things always add to our workload, but that's not unique to us because we can see this is adding to Maninder's workload, to your workload, Henry, everybody's workload. So that's not unique to primary care, but I guess we're very conscious of that. So thanks so much. We might kind of wrap things up so we finish on time. So I think we've got, and I should say also the presentations will be circulated. So if you didn't catch the QR studies, that you'll be able to get those sent out to GoldNet, including, of course, those online tonight. There's a couple of other studies that we're supporting at the moment. Acceptability and feasibility of using microbial polygenic risk scoring for type 2 diabetes. a qualitative study. That's a very interesting idea, that gut microbiome and it's linked to type 2 diabetes and whether that has an influence. So you can see there about the eligibility and what would be involved, and there's a QR code. We love QR codes. So for those to get further information, of course, is on the website as well. Any more, Ali? Oh, yes, treatable traits in COPD, the terracotta trial. I'm involved in this. I have to own up that I'm one of the investigators here, so conflict of interest, but this is one being run from Monash about this idea of treatable traits in COPD, things like inflammation and tendency to exacerbations, things you might be able to pick up and do something about. It's a cluster randomized trial, and they're trying ambitiously to get 500 patients. This is for general practices that have at least 500 patients in their database, have a practice nurse. So that's another study we're supporting at the moment. Or if you're not a member already and you'd like to become a member of GoldNet and be invited to our face-to-face events, the online journal clubs, hear about different research studies, and I should say it's also a teaching and research and education network as now. So there's things aimed at people with an interest in education as well, like our recent things we've done about use of AI both in teaching and in so there's how you join up. And we're coming up to 8 p.m, so I so very much thank all our participants. Thanks, Maninder. Thanks, Henry. We've had some really high-level, interesting input here, both a national perspective and the local perspective. Wish you luck in dealing with all those patients, Maninder. I'm sure you wish us luck in dealing with all the incidental omas as well. We're going to be jointly challenged by that. And thanks, everybody, for their participation tonight.
Thanks.
Thank you.
Thanks everyone.
Thanks, everyone.
Bye.